everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm a former journalist, and more importantly, I'm the mom of a preemie, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, I'd ask you to head over to CanadianPreemies.org, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. We've been making lots of changes to the website lately, so check it out, explore some of those changes, especially look at our printable section where it's all free resources for your use. And that's CanadianPreemies.org. Let us know what you think. Today's session is live, so we'd ask that you bring your voice to the table. There is a chat section. You can leave your comments, let us know where you're watching from, questions, and we'll try to address those today during our program. It is through rich conversations like these where we can advance practice and learn together and from each other. So please participate and let us know where you're coming from. It's always interesting to see where people are tuning in from. Now, on to today's topic. As we know, there can be many complications for our little ones when they're born prematurely. One such complication is neonatal acute kidney injury. Today, we'll hear how common it is, short-term and long-term effects, and the signs that can help us recognize when it's present in our premature babies. Follow-up is especially important, and so that will be touched on as well. And to lead us in the discussion, I'm happy to be joined by Dr. Mina Hanna. He is an associate professor of pediatrics at the University of Kentucky and senior neonatal medical director at Kentucky Children's Hospital. He's active in professional organizations such as the Neonatal Kidney Collaborative, and that's also known as NKC. And the NKC's mission is to improve the health of newborns with or at risk for kidney disease through multidisciplinary collaborative research, advocacy, and education. Welcome, Dr. Hanna. Thanks for joining us.
Thank you. Thank you for the introduction. It's a pleasure really to be here and talk about something that I have a lot of passion about.
I'll let you get right to your presentation today, and then I'll pop back on after with some questions.
Great, thank you. Again, thanks for the introduction and thanks for the invite. I have nothing to disclose. The outline, today I'll be talking about the incidence and definition of neonatal acute kidney injury, and we'll talk about the association between acute kidney injury or AKI and other neonatal morbidities. And we'll talk about recent studies that looked at risk factors and outcomes of neonatal AKI. So a little bit history about neonatal AKI or about AKI. It was first described during the World Wars when it was noted that a blunt trauma to the abdomen can induce renal cortical vasospasm. So post-traumatic oliguria was seen in soldiers, and crush syndrome evolved as AKI. And then in the 50s and 60s, AKI was found in about 20% of adults who had open heart surgery. In the pediatric literature, the acute kidney injury or renal failure, as it was described at that time, was first defined in kids who have what we call hemolytic uremic syndrome or HUS. It's an post-infection renal destruction So that was how first renal failure was described in kids. And then because of the increased research in adult and pediatric patients, we started realizing that even small changes in serum creatinine may be significant, and that children and neonates can die from acute kidney injury, not just with acute kidney injury. So meaning that acute kidney injury is an independent risk factor for mortality in children and neonates. And then we're realizing more and more that neonates who have acute kidney injury are at higher risk for developing chronic kidney disease and hypertension later on in life. I'm not sure why this slide is not showing. So how do we define AKI? It's a decrease in glomerular filtration rate to a level that's insufficient to filter or excrete solute and water and maintain the fluid and electrolyte balance. So some of the older definitions, we used to look at urine volume as a marker for kidney injury. However, urine volume is a poor indicator of renal function, and most of kidney injury in neonates is non-oliguric. Serum creatinine, increase in serum creatinine above certain level, above like 1.5 milligram per deciliter, but also serum creatinine has several limitations that I'll talk about. A daily rise in serum creatinine, that's probably more reflection of decreasing kidney function. We don't have a reliable method to measure glomerular filtration rate in neonates. So some of the limitations of serum creatinine is that there is a lag between the time of renal injury to the time of creatinine start rising. So about 25 to 50% of kidney function is already lost by the time creatinine start rising. Also, creatinine is a marker of kidney function, but it's not really a marker of kidney injury. So for example, when we think about like MI and myocardial injury, we measure troponin and CKs, but we don't have a similar reliable marker for kidney injury. So creatinine reflects more kidney function rather than kidney injury. And it does not specify the site of renal injury, whether proximal or distal tubular injury. It can also overestimate the renal function because of the tubular secretion of creatinine. And it's affected by different medications, bilirubin and muscle mass. And once you start renal replacement therapy and you're removing creatinine, it's difficult to use the serum creatinine as a prognostic biomarker. In neonates, that's also added. There is also another factor that the initial post-renal creatinine reflects maternal values, and the creatinine clearance changes as growth and renal development occur. So the most accepted and tested also definition for neonatal AKI is the one that's shown here that divides acute kidney injury into 3 stages, where stage 1 you have a serum creatinine rise by more than 0.3 within 48 hours, and then stage 2 and stage 3 where you have higher rise of serum creatinine or a more decrease in urine output. If we look on the epidemiology of AKI in children, you can see that about 1/4 occur in the first 30 days of life. So neonatal AKI accounts about for almost 25% of AKI. In neonates, there are certain groups that are at higher risk for acute kidney injury. Preterm, and we'll talk a little bit about preterm and the risk for AKI. Term neonates who are sick, who need ECMO, neonates who have congenital heart disease, and neonates who have hypoxic ischemic encephalopathy or HIE. So if you look on the incidence of AKI in those groups, it varies. So in preterm, whether very low birth weight or extremely low birth weight, the incidence is probably around 12 to some studies up to 30%. In term or near-term neonates who are sick and those who have sepsis, it's about 25% or 26%. In term neonates who have hypoxic ischemic encephalopathy, it's up to 38%. And in neonates who need ECMO, it's about 70% incidence of AKI. So looking on nephron formation in fetal life, as you can see that nephron starts forming around 9 to 10 weeks gestation, and then there is an exponential increase in nephron numbers. So about more than 60% of the nephrons are formed in the third trimester of pregnancy. And then we end up with around 1 million nephrons around 34 to 36 weeks gestation, and that's when nephron formation stops. So just imagine that preterm infants who are born at 23 or 24 weeks, the majority of their nephrons are going to be formed in a different environment than what it's supposed to be. And there are several factors that affect nephron formation during in utero and early postnatal life, starting from maternal nutrition, maternal medication exposure, and then postnatally neonatal medication exposure. A lot of the medications that we used in the NICU are nephrotoxic. Also, neonates are exposed to infection and hemodynamic instabilities and different nutrition. So those are all can be risk factors for that can affect the nephron formations. So if we look and see if nephrons are, how are nephrons formed in preterm infants? So this study was looking at autopsies from kidneys, and you can see that if you look on the radial glomerular count or RGC as a reflection of nephron formation, you can see that preterm kidneys don't really don't continue to form nephrons after 40 days of life. Then the other question is, are the nephrons that preterm are forming, are those normal nephron? And this study also looked again on kidney autopsies, and they found that the preterm kidney had there is more abnormal glomeruli compared to gestational controls. So preterm kidney have fewer functional nephrons, and that increased the risk, the vulnerability to impaired renal function, both in early neonatal life and also later in life. This is the same study comparing the glomeruli in preterm kidney and compared to control gestational controls. So what do we know about the association between acute kidney injury in the different neonatal populations and other comorbidities? So we know that in term neonates who had hypoxic ischemic encephalopathy who were treated with therapeutic hypothermia, the ones who had AKI had longer duration of hospitalizations. They spend longer time in the NICU. They spend longer time on mechanical ventilation, and they had higher incidence of mortality. Similarly, also babies who had congenital heart surgery, the ones who had AKI had longer ICU stays, longer duration of mechanical ventilation. There was higher risk for needing inotropic support post-operatively, and higher mortality. The neonates who have congenital diaphragmatic hernia who require ECMO, the ones who have acute kidney injury tend to have longer ECMO runs, longer duration of mechanical ventilation, and lower survival. And next, I'll talk about the AWAKEN trial that came out of the NKC, the Neonatal Kidney Collaborative. This was a multi-center, multinational observational study that looked on the epidemiology of neonatal AKI and screened more than 4,000 neonates, and a little over 2,000 neonates were enrolled. And currently, there are more than 20 publications that came out of that cohort. Early on, the earlier papers looked on the incidence and outcomes of neonatal AKI, and then the secondary papers looked at risk factors for early and late AKI, early defining AKI happening in the first week of life, and the association between AKI and other morbidities, such as intraventricular hemorrhage or IVH, bronchopulmonary dysplasia, and fluid balance. So looking on the incidence of AKI, it's a U-shaped incidence. So there is a high incidence in preterm neonates, less than 29 weeks. The incidence is almost 50% of those neonates had AKI. And then there is also high incidence in the more than 36 weeks neonates who needed to be admitted to the NICU. So those are either sick neonates or had hypoxic ischemic encephalopathy. The incidence in that group is 37%. But even in the group in between, the babies who are what we call moderate preterm, between 29 weeks gestational age and 36 weeks gestational age, even in that group, the incidence is not insignificant. About 20% of those babies had acute kidney injury. So looking at trying to find a better definition for acute kidney injury in this cohort, what was seen is that if we have a unique serum creatinine rise cutoffs for different gestational age, that improves the outcome prediction. There was no difference between the using the absolute change in serum creatinine versus a percent serum creatinine rise. It did not add to the neonatal AKI definition. And as you can see, as the absolute or the percent serum creatinine rise threshold increased, the mortality is higher. Looking on some of the outcomes in the AWAKEN cohort, again, the neonates who had AKI had an odds ratio of 7.5 of mortality, and also had a higher length of stay. The secondary studies that came from the AWAKEN looked at risk factors and different morbidities associated with AKI. So we know that early risk factors, that the early risk factor people looked at some of what are the risk factors for AKI, and that it's also associated with death and longer duration of hospitalization, and also that late AKI is common and associated with poor short-term outcomes. One of the studies that looked on caffeine, and I'll talk about that later, found that babies who were exposed to caffeine were less likely to have AKI and less likely also to have severe AKI. There was an independent association between AKI and head bleed or intraventricular hemorrhage. And in babies who had HIE, around 41% had AKI, and those who had AKI had longer duration of stay. Also looking at AKI and association with chronic lung disease and fluid balance. So preterm or term who had AKI had tend to have higher fluid balance or positive fluid balance, and also ended up needing longer duration of mechanical ventilation. And there was also association with developing chronic lung disease. Also, of the neonates who had AKI, around 30% had PDA, and lower hemoglobin in the first postnatal week was associated with late AKI, and also low albumin level was independently associated with early and late AKI. So looking on some of the long-term follow-up for neonates who had AKI, this study is a little bit over 20 years old now, but I think it's really important because even though it had a small number, but those were extremely low birth weight infants with birth weight around 600 grams and gestational age around 25 weeks that were followed for around 7.5 years. And you can see that only 11 out of the 20 had normal kidney function, 4 had chronic kidney disease, and 5 progressed to end-stage renal disease. Another more recent study looked at also acute kidney injury and follow-up, and you can see that those who had AKI had lower glomerular filtration rate. This study, I think, followed the kids after discharge from the NICU for about 4 or 5 years of age, and you can see that those who had AKI in the NICU had lower glomerular filtration rate at that time during the follow-up. And it's as expected, it tends to be noted more with the higher degree of acute kidney injury. So with stage 2 and stage 3 AKI, those kids had lower glomerular filtration rate. This was a study from Europe that looked at growth restriction and kidney function at around 7 years of age. And again, preterm who were growth restricted, whether intrauterine or extrauterine growth restriction, there was higher incidence, or they had lower glomerular filtration rate, or as a marker of chronic kidney disease when they're followed. So this was a systematic review for observational studies that looked at albuminuria and stage renal disease and decreased glomerular filtration rates, all as markers of chronic kidney disease. And you can see that low birth weight is associated with all the 3 markers of chronic kidney disease. So according to the Brenner's hypothesis that preterm, again, they start with the lower nephron numbers, and then they're exposed to nephrotoxic medications in the NICU, they're exposed to infection, they're exposed to a different environment. So the decreased nephron numbers, they end up with what we call hyperfiltration or glomerular hypertension, and that put them at risk for developing proteinuria and systemic hypertension later on. And then they can end up with chronic kidney disease. So I hope that I've been able to show here that prematurity predisposed to acute kidney injury, and having acute kidney injury in the NICU predisposed to chronic kidney disease, but also prematurity by itself predisposed to chronic kidney disease. Another group of studies that came out of the PEANUT trial, the PEANUT trial was looking at erythropoietin for neuroprotection, but also there were secondary studies looking at acute kidney injury in this cohort, and you can see that with severe acute kidney injury there is a higher mortality, and some of the risk factors for kidney disease and elevated blood pressure in this cohort, that they were born extremely preterm. So the lower gestational age and lower birth weight had lower glomerular filtration rate and had higher diastolic blood pressure. Maternal preeclampsia and maternal hypertensive disorders tend to be protective or against AKI. We don't know the mechanism exactly, but this has been seen in a few studies. Also, prenatal steroids is associated with less incidence of decreased glomerular filtration rate. So this study has shown that for every 1 week higher gestational age, the odds of having decreased GFR less than 90 was lower by 6%. Again, highlighting that the difference between nephron formation in utero and for preterm birth. And for every 1 standard deviation higher birth weight, the odds of having a glomerular filtration rate less than 90 was also lower by 8%. Looking at whether erythropoietin is protective for kidney function, the babies who were randomized to erythropoietin were less likely to have a systolic blood pressure, so more than 90th percentile compared to those randomized to placebo. And this is the study that I mentioned earlier, looking at another possibly drug that can be protective from acute kidney injury. So babies who were exposed to caffeine, and we used caffeine for neuroprotection and for apnea of prematurity. So babies who were exposed to caffeine had lower incidence of acute kidney injury. And there was whether for early and for any AKI. And then finally, I just want to also point to another important study that looked at how often do we document acute kidney injury for babies at the time of discharge from the NICU. And I think this highlights an opportunity that we have, that we should be doing better in documenting acute kidney injury at the time of discharge, and making sure that those neonates preterm and those who had AKI are going to have the appropriate follow-up after discharge from the NICU. And I just want to point to the NTC website. I think it's a great resource for healthcare providers and for parents. And my email for any questions. Thank you.
Thank you so much for your presentation. I put the link for that website, babykidney.org, in our comments so people can visit and explore on their own. We do have a question from Kieran, who's watching, and she asks if there's any connection between AKI and kidney infections or kidney stones.
That's a good question. I'm not aware about babies who had AKI that they're at higher risk for kidney infection. I think there's probably a higher risk for nephrocalcinosis or kidney stones later on if there is a decreased kidney function.
And I'm wondering if there is a standardized definition of AKI, or is it that spectrum of numbers that people are looking for?
Yeah, so that's a good question. So the definition has changed over time, and it came first from the adult and then from the pediatric definitions. But I think we have now a more standard definition, the one I showed on the table that has been tested in several studies. That tends to be the most accepted definition now. It's called modified KDIGO. Again, the limitation is that it depends on the serum creatinine, and creatinine has several limitations. So hopefully in the future with new biomarkers coming on and being tested in several studies, that when we have better biomarkers, we're probably going to have better, more robust definition for AKI.
We have another question from Kieran. Anything we should look out for in older preemies as signs of chronic kidney disease?
Yeah, that's a great question. Again, I think all preemies are at risk for chronic kidney disease later on. And we recently had a meeting in February, and there are going to be some recommendations published about different neonatal populations, whether extremely preterm or late preterm, that those babies after discharge from the NICU, they need to have close follow-up and at different time points, measuring blood pressure, looking at kidney function, and having some sort of kidney education, at least for the first 2 years after discharge from the NICU.
And that's not something that's happening right now, correct?
Correct. Even though there are some recommendations by the American Academy of Pediatrics about like measuring blood pressures, that's not really happening. And we tend to, it's unfortunate, but I think we tend to focus more on like lung and respiratory and brain development, but kidney is important as well.
Yeah, and it sounds like based on your charts of looking at what other morbidities can go with reduced kidney function, that it's something that should be looked at as much as those big ones that we hear a lot about.
Absolutely, yes, definitely. It's an important organ, and there is also a lot. I think there is more and more research now showing the crosstalks between the kidney function and lungs, and kidney function and heart, and kidney and brain. So it does affect other organs as well.
It's always interesting to me how tied in those systems are to each other. And even the numbers that you're showing are like tiny little changes, but it could indicate a bigger problem. I remember as a parent being like, oh, really? Is point something the huge difference? But it actually can be the big difference.
Yeah, absolutely. Yes, exactly. Even though it might seem as a small change, but it can make a big difference later on.
You mentioned that especially in the third trimester is when those nephrons are really being developed. And so is it accurate or fair to say that all preemies have some kind of kidney injury, perhaps just not what you'd classify as an acute kidney injury, where they don't have those nephrons developed?
Yeah, that's a great question. I, I'm not sure how you're correct. I'm not sure what to call it exactly, but you're right. Those preterm, they have some degree of kidney dysfunction or kidney dysregulation, even if they don't meet the definition of having AKI, but just by being born early, their kidney is not functioning as compared to term, if we compare to term babies.
And is it something that can be missed until, you know, if it's a number that kind of floats under the radar, can it be something that emerges much later in our preemies' lives?
Yeah, that's also a great question. It depends on how often we're looking for it. So um, there is a large variability between different NICUs on how often do they check kidney function. I think in the Awaken cohort, it ranged between 2% to 50%, depending on how often you're checking the creatinine and kidney function. So if you're not checking it, you're more likely to miss it.
Hmm. And the study that you referred to, I thought it was really interesting that you used, I referred to a study that was 20 years old, which I'm a parent, so I have limited experience, but in my experience, the older the research, the less reliable it is. And so, has there been changes that would change that research that has been done? Is this something that needs to be studied now that's kind of understudied, or is that still something we can go back to and say, yeah, the science is the same as it was 20 years ago?
Well, that's a good point. We're also we're having more and more preterm babies, so we're having now 23 more 23 and 22 weekers, and this is definitely a population I think that's under studies, and they're definitely different from babies born at like 28 or 30 weeks, even though they're all preterm. But I think the lower gestational age are probably at higher risk for uh, later on hypertension or chronic kidney disease, and we don't know that yet.
So it's perhaps something that families can advocate for when they have follow up with their preemies. They can
Yes,
ask for those studies to be done.
yes, we definitely need that.
Well, thank you so much for joining us here today. You've given a lot of food for thought. And as Kieran commented, she has an appointment next week. So she said that gave her a lot of information to go into that appointment. And I certainly learned a lot. And so thank you so much for joining us here today and for sharing your wisdom and knowledge on this topic.
Thank you for inviting me. It's been my pleasure.
And thank you, everyone, for being here today and for bringing your questions and for letting us know where you're watching from. Preemie Chats is something that is very dear and near to the heart of CPBF. And so a special thank you to AstraZeneca for their ongoing support of educational programs such as this one. And I want to remind you that if you missed any part of today's episode, then you can again go to canadianpreemies.org. There you will find this full episode plus over 300 other episodes that cover a variety of topics. You'll also be reminded on that website that CPBF is a charity. And there's lots of free resources and support options available there. But CPBF needs support to continue this kind of work. And so as you explore their website, think about different ways that you can get involved with CPBF and support their mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I'd invite you to join us here next Friday at 1 p.m. Eastern Time as we discuss the most common complication related to preterm birth, bronchopulmonary dysplasia, or BPD. You won't want to miss it. In the meantime, I hope you all have a great weekend.